Good morning, everyone. Myself, Dr. JUHI, and I am here today to present my topic, Impact of Telemedicine on Diabetic Retinopathy Screening to Overcome Current Challenges in India. As we all know, diabetic retinopathy prevalence is higher in developing countries like India, where health economic burden with referral of the patient is a major concern. Patients with diabetes are unaware of the importance of regular eye exams and asymptomatic progressive nature of early disease. The expected global prevalence of diabetic retinopathy is going to increase from about 103 million people in 2020 to about 130 million in 2030, and the current screening strategies have poor compliance. There are many barriers to screening, like lack of awareness, socio-economic factors, healthcare system fragmentations, and doctors' shortage. Thus, a comprehensive diabetic retinopathy screening program is an urgent need of the hour. My study is a retrospective study which includes type 2 diabetes mellitus people referred to physician's clinic between December 2023 to May 2024 for routine follow-up visits. Single field non-mydriatic fundus photos were obtained with a retinal camera. There was a trained technician who segregated the images into a screen negative and screen positive images. The screen negative images were considered non-referable, that is, images with no or mild NPDR. The screen positive images were those images which contained moderate to severe NPDR, PDR, or macular edema. The retinal images were then sent to Retina Clinic using a Telegram Messenger app for review. The screen positive were referred to Retina Clinic for direct retinal examination. The rate of attendance was marked at the Retina Clinic, and follow-up visit was scheduled, and a reminder system was also sent for timely visits. Patients were informed of screening results and received education about consequences of diabetic retinopathy. This is a flow chart showing how our Nidec camera auto focuses the retinal lesions and auto switching from anterior eye to fundus. These are the results. There were total 1200 patients, out of which 310 patients turned out to be screen positive fundus images. Out of those 310, there were 189 patients who attended the retina clinic. Out of those 189 patients, there were 120 patients who had severe NPDR, 23 patients had PDR, and 10 patients had macular edema, and 36 patients had moderate NPDR. It was seen that the screen positive patients were significantly older, had higher systolic blood pressure, and longer duration of diabetes. There was no significant difference seen between HbA1c levels, diastolic blood pressure, and percent of insulin users between the two groups. It was seen that holistic healthcare programs such as screening and assessment of diabetic foot, structured diabetic education sessions at the physician clinic were associated with greater adherence to diabetic screening. The need for structured program in diabetic retinopathy is to provide pathways for timely referral to increase patient adherence and also detection of undiagnosed retinopathy in a diabetic who would not otherwise visit retina clinic. While integrating routine patient care in physician clinic with diabetic retinopathy screening program, we increased screening coverage and also increased identification of diabetic retinopathy in asymptomatic cases, enhanced the efficacy of the screening program wherever qualified eye care professionals were not available. The clinical implication of this study is that it provides opportunity for timely intervention, reduces the disparities in access to eye care, it streamlined the eye care delivery, reducing the need for separate eye appointments. Patient education and awareness was increased, and there was overall improved diabetes management seen. The conclusion of this study is that my study has shown how telemedicine can significantly improve access to diabetic retinopathy screening and diagnosis, particularly in underserved areas, by enabling remote retinal imaging and expert consultation, leading to cost-effective, early detection, timely treatment with diagnostic accuracy comparable to in-person examination, with reduced screening burden at the retina clinic, and reduction of undiagnosed retinopathy in a diabetic who would not otherwise visit a retina specialist. Thank you.
So do you think that if it would be more relevant if we have something like this at the place of where people come for their blood samples, or like a pathology clinic or a endocrinology clinic, as well as doing it specifically for diabetics only, all these areas of check?
Yes, ma'am, sure. Like this study is conducted on patients who are already diabetic and came for routine follow-up visits. So if there, like a patient has diabetes and comes to physician clinic for routine follow-up, then we can definitely screen the patient and then send the fundus images to a retina specialist, and then further screening and segregation of patients according to treatment can be done.
So this telemedicine center was where was it exactly?
So the studies was done at Gorakhpur, where I was previously. So like in Gorakhpur only, there was a physician clinic. We coordinated with them, and then it was done.
Yeah, that's what I mean. Yeah,
yes, ma'am.
good.
So fundus camera should be installed at physician's clinic
Yes,
as well
Yes.
as labs.
yes, sir.
No, that's, I think, a good idea also. If you have the facility of more, because there specifically you can target the patients who are coming for a routine check, so they
Yes.
can also have their
Yes, ma'am.
fundus checked.
They
as
are
well.
already
Because
diabetic.
diabetics know that they have to get their blood sugar
Yes,
tested.
ma'am.
Yeah.
Yes.
So it was a portable fundus camera which you used to carry to the
No,
physician's
ma'am, it
clinic?
was NIDIC camera.
It was a portable, you used to carry it, or it was
No,
installed
ma'am, that
there?
was installed.
Installed there
Okay.
only.
Thank you.
Thank you.
Thank you.
Thank you so much.